Hello, students. Yes, I know, I'm sure you're working really hard. And yes, now we are just going to see what the NEET ENT questions were in the last NEET. And yes, this will give you an idea. It will tune your mind to what the pattern of the questions is going to be in the next NEET also. So let us quickly start. The first question we have here is name the bone. Okay, so we are seeing some bone here and the choices is malleus, incus, vomer and stapes. So definitely we know it is not vomer. We also know it is not stapes. So we have two things in mind. One is the malleus and the other is incus. What do you think this is? Is this malleus or is this incus? Yes, when this question came, few of us, the students told me that it was such a bad picture that we got confused whether it was malleus or incus. Now, please always remember, yes, the malleus always has a head, right? It has a neck and then it has the lateral process, the anterior process and the handle. So we can say it has three processes. Okay, it has a lateral which points towards the tympanic membrane, anterior towards the anterior wall, and then we have the handle of malleus going down, right? Okay, now the stapes also has a head and it has a neck and then it has true crura. Anyway, we can never confuse whether this ossicle that we are seeing is stapes or not. It is totally different in shape. Now, how is the incus? Incus has no head, so it will not have a neck, right? Malleus and stapes have a head also, so they have a neck also. Whereas in incus, we directly have a body and then we have a short process and then we have the long process, right? And it ends in a lenticular process which articulates with the head of the stapes. Now, always remember that these processes are like limbs. They are like limbs, like hands. Yes. So, do the limbs ever arise from the head area? No. Limbs always arise from the body. Which means that if you are seeing some processes coming from the upper part of some ossicle, it means that that part of the ossicle is not the head. It cannot be the head because the limbs can never arise from the head. Limbs always arise from the body. It means that that part of the ossicle is a body. And which ossicle directly has a body? It has no head and no neck. Yes, that is the incus. So that is how you are going to identify. Is that clear? So now when you see this picture again, can you make out now that we have one process here, we have one process here, it is directly coming out from this part, which means this cannot be the head, it has to be the body. And which ossicle has no head, no neck, directly a body? That is the incus. So yes, the answer here is incus. Now, yes, see this picture? Can you make out now? Yes, this we can make out. Can you see the malleus and make out that this is malleus? Yes, if this picture is given, yes, we can see that there is definitely a head, a neck, and then these processes are coming out. Now, in this picture, yes, so no matter how bad the picture is, yes, when your mind knows, your eye will see that. Yes, so this we can see one process is coming here. Yes, so this is the directly the body because the processes are coming out directly from here. So this has to be the incus. Whereas here we are seeing this is the head, a beautiful head, we have a beautiful neck, and then we have the processes, right? We have the processes coming out. So this has to be the malleus. Now coming to the next question. A 70-year-old male presents with decreased hearing in higher frequencies. It was noted that the basilar membrane was affected. Which of the following structures lie near the damage? Okay, so we have certain structures being given: modulus, trivascularis, oval window, helicotrema, and we have to identify which of these structures lie near the damage. Where's the damage? The damage is in the basilar membrane. Okay, the basilar membrane was affected. Where is the basilar membrane? Basilar membrane is present in whole of the scala media, yes or no? Yes, on the basilar membrane is present the organ of Corti. Organ of Corti is present in whole of the scala media. So which means that basilar membrane is present in whole of the scala media. So is the whole of the basilar membrane affected? If the whole of the basilar membrane is affected, it means whole of the organ of Corti will be affected, which means all the sounds will be affected. But here what we are seeing is that there is decreased hearing only in the higher frequencies, which means that the organ of Corti or the basilar membrane has got affected only in the higher frequencies. Do we know higher frequencies is in which turn of cochlea? Where is the higher frequency in the organ of Corti? Yes, in the basal turn of cochlea, which means that we have identified the damage to be in the basilar membrane or in the organ of Corti in the basal turn of cochlea. Basal turn of cochlea, right? Okay, so now what we have to find out is that which of the following structures lies near the basal turn of cochlea. Is that clear? Okay, so now what is the first choice? The first choice is modulus. Okay, where is modulus? What is modulus? We have read that modulus is the central axis around which the cochlea takes 2 3/4 or 2.5 turns. Right? So, is the modulus related only to the basal turn of the cochlea specifically? Because we have to specifically find out the structure which lies near the basal turn of cochlea. So no, modulus is related to all the cochlear turns. It cannot be modulus. Okay. Next choice is triavascularis. What is triavascularis? Yes, whenever we have read the structure of the scala media so many times, and what we have seen there is that we have the rhinous membrane, we have the basilar membrane, laterally we have the triavascularis, right? This is the scala media, above that is the scala vestibuli, and below that is the scala tympani. Yes, so wherever there is scala media, laterally we have the triavascularis. So triavascularis is not limited only in the basal turn. In whole of the scala media, from the apex to the base, we will have the triavascularis, the site of production of endolymph. So again, that also will not be related only to the basal turn. So this also is not the answer. Now we have two more choices. One is oval window and the other is helicotrema. Okay, helicotrema. Do we know helicotrema? Yes, we know. Where is helicotrema? Helicotrema is at the apical turn. It is where the scala vestibula and the scala tympani, they communicate at the apex of the cochlea. That is helicotrema. So that is again not the basal turn. So that also cannot be the answer. The answer looks like the oval window. So is the basal turn of cochlea related anywhere to the oval window? What does the basal turn of cochlea produce? Yes, the basal turn of cochlea produces promontory on the medial wall. We know that on the medial wall of the middle ear, the basal turn bulges to produce the promontory. Is oval window somewhere in relation to the promontory? Yes, it lies posterior superior to the promontory on the medial wall. So yes, the answer is the oval window. So a quick look we have here. Yes, so just see here, this here in the center. In the center, that is the modulus around which the cochlea takes the various turns. So the modulus is in relation to all the turn, the basal turn, the middle turn, the apical turn. It is in relation to all the turns of the cochlea. So what do we have here? Okay, so here we have the scala vestibuli, we have the scala media, and we have the scala tympani. Right? And when we take a cut section from any of these turns, the basal turn, the middle turn, or the apical turn, in the center we can see is going the modulus, right? These are the turns around the modulus, and in each of these turns when we take a cut section, what do we see in the cut section? We see, yes, we have the scala vestibuli, the scala tympani. In all the turns it is scala vestibuli, scala tympani. In the center is the media, where we have the rhinous membrane, the basilar membrane, and laterally we have the triavascularis. Yes, so rhinous, basilar, and laterally the triavascularis. Same for all. In all, we will have the triavascularis. So triavascularis will not be limited only in the basal turn, right? So when we have a look here, what we are seeing is that this here is the basal turn of cochlea. The basal turn is producing promontory on the medial wall. This is the promontory, and above that, posterior superior to that, is the oval window, right? So yes, that is in relation to the basal turn. So the answer there is the oval window. Is that clear? Yes. So just one by one, step by step, just when you try to decipher and dissect the question, you will come to an answer. So everything that will be asked, you have read it. Coming to the next question. 5-year-old child presents with reduced hearing for the past 2 to 3 months. Most likely diagnosis is. Okay, so this is a 5-year-old child. Complaint is only one, reduced hearing, and that too for past 2 to 3 months. Most likely diagnosis. The picture also has been given here. What do you think is the diagnosis? Yes, always remember, whenever it's a child with hearing loss, That is the only thing that has been given in the question. Child with hearing loss, whether it is mentioned bilateral hearing loss or just mentioned hearing loss, a child with hearing loss, no pain, nothing. Yes, the thing that should come to your mind first is always what? Always serous otitis media. Yes, why I am telling you is that read the question and diagnose, because most of the time when the picture is given, the picture is not needed. Here also in this question, even if the picture was not given, the answer wouldn't have changed. And then what you do is you read the question and you are so much in a hurry to see the picture that okay, whatever is in the question, just forget that picture. Oh, this picture, I can see some bulla. This is appearing like myringitis bullosa. Rest history have forgotten. That is why I am telling you that when you are reading the question, read the question properly. Yes, this was, many of the students told, oh, the picture was so bad, we thought it was bulle that we were seeing. First, read the question properly, then see the picture. Okay, so here it is a 5-year-old child, where the picture is given or not. Any child with bilateral hearing loss, any child with only hearing loss, no other complaint, no pain, has to be serous otitis media. Similarly, a question that has been asked very, very commonly in your exam, a child with nasal obstruction, with mouth breathing. Yes, the moment I say this, what comes to your mind? Child with nasal obstruction, with mouth breathing. Yes, adenoid hypertrophy. So is adenoid hypertrophy also the cause of serous otitis media? Obstruction of both the eustachian tube because of hypertrophy adenoid? Yes. So whenever this presentation is given, always think of, if it is ear that is mentioned, it has to be serous otitis media. If it is the nose that has been mentioned, or mouth breathing, features of nasal obstruction, then it has to be adenoid hypertrophy. Yes, last year was adenoid hypertrophy given and the picture was given. Again, you see the picture and you think that what it was. No confusion at all should be in your mind. So now let us see. Okay, now tell me why not A. The choices is myringitis bullosa. Why this picture, why this child cannot be myringitis bullosa? Myringitis, itis, this itself tells you, by chance you don't know what is myringitis, you have forgotten what is myringitis. What is myringitis? Myringitis, the name itself tells you myringitis. It is an inflammation, acute infection of the myrin tympanic membrane. Acute infection, it cannot be 2 to 3 months. Yes, and acute infection, it is infectionitis. It has to be painful, not only hearing loss. So it cannot be myringitis bullosa. This is an infective condition of the tympanic membrane where there are bullae that you see on the tympanic membrane. Yes, it is infective, so it is very painful and it is an acute condition. Acute otitis media, same. It is acute condition, very painful. So it will not be for 2 to 3 months and not only with hearing loss. So again, this cannot be. The answer is yes, serous otitis media. And pneumotympanum, what is pneumotympanum? Air in the middle ear. That is normally there. Pneumotympanum is no specific condition. Now coming to the next question. A patient presents with a complaint of inability to close the eye and deviation of angle of mouth. Which of the following nerves is most likely to be affected? Okay, so here what is the complaint of the patient? There is inability to close the eye, this is one, and the second is deviation of angle of mouth. Both these things are there, so one half completely of the face. The eyes is also not closing and deviation of angle of mouth also. Which of the following nerves is likely to be affected? Let us see the choices. First is facial nerve. In facial nerve, will there be inability to close the eye? Yes. Deviation of angle of mouth? Yes. So yes, in lower motor neuron facial nerve palsy, complete one half can be affected and both will be seen. This can be the answer. This can be the answer. Let us see the other choices. Trigeminal nerve. In trigeminal nerve involvement, yes, what is trigeminal? Trigeminal is mainly a sensory nerve. So, which feature of the eye will be seen? Inability to close the eye? No. Trigeminal nerve, there will be loss of corneal reflex. There will be sensation of the eye which will be gone. Ophthalmic, maxillary, mandibular. These are the three branches of trigeminal. So, there will be hyperesthesia or severe pain in the sensory distribution of the trigeminal. Never inability to close the eye. Deviation of angle of mouth. Deviation of angle of mouth in trigeminal. Trigeminal also supplies the masticator muscles. So on opening the mouth, the jaw can get deviated to, there can be deviation of the jaw to the paralyzed side. The normal side will push it to the opposite side. But both these, or it is deviation of the angle of mouth? No, not in trigeminal. It cannot be trigeminal. Oculomotor nerve, the third nerve, yes, that can affect only the eye, and in the eye also it will lead to ptosis, not inability to close the eye. So no. Glossopharyngeal nerve. Glossopharyngeal nerve, what does it supply? Yes, it stays to the posterior 1/3 of the tongue. So there will be reduced taste sensation. There will be reduced general sensation over that area. So gag reflex will be absent. The only motor of glossopharyngeal is stylopharyngeal. So there can be some dysphagia. But these two, no. So the answer is yes, facial nerve. So coming to the next question, a patient with a history of asthma and sinusitis, on looking into books, it is attributed to Samter's triad. Which drug should be avoided in this patient? So they've clearly given that this is the patient of asthma and sinusitis and Samter's triad has been diagnosed. So what is Samter's triad? We have read so many number of times. Yes, it is aspirin hypersensitivity, aspirin sensitivity leading to asthma and nasal polyps. Nasal polyps. Nasal polyps. Yes, recently 2 years back was this asked, which is the component of Samter's triad. So it is nasal polyps, it is asthma, and both these are exacerbated by aspirin. So aspirin sensitivity. In other words, this Samter's triad is also known as AERD or aspirin exacerbated respiratory disease. Yes. So what is the drug should be avoided? Yes, aspirin. So the answer is aspirin here. So coming to the next question. A post-COVID patient who is a known diabetic develops unilateral facial pain and loosening of teeth. Which next investigation would you do? Okay, so he's a post-COVID patient, so probably he was on steroids, so that depicts the immunosuppressed status. Again, diabetic, so immunosuppressed, and he has now come to you with a complaint of unilateral facial pain and loosening of teeth. Whenever such patient comes to you, what is the first thing that you would like to rule out? Yes, very good, mucormycosis. And not only after COVID has mucormycosis become a favorite topic of your exam, it always was. Always. It was a favorite question of your exam. So yes, we now would like to rule out whether it is mucormycosis or not. Which next investigation? Let us see the choices. The first choice is MRI. Will MRI confirm that this is mucormycosis, or will a CT scan confirm that this is mucormycosis? Tell me. No. CT scan and MRI are not for the diagnosis. They will tell you the extent of involvement. They will also be helpful when you want to see the resolution of the infection. Then you can get a repeated serial CT scan done to see the resolution of infection, but not for diagnosis. No, so this is incorrect. This is incorrect. Nasal swab for mucor. Yes or no? Yes. So the moment you suspect that this is mucormycosis with this type of history, what you're going to do is you are going to subject this patient. You want to rule out a rhinocerebral mucormycosis. So you are going to subject this patient for nasal endoscopy. Yes, and in endoscopy, what are the findings that you will find is the black appearance or a discolored mucosa. And this black appearance, is this the black appearance of the fungus? No, this is known as black fungus, not because it appears black. Why? Because this black that you are seeing is the necrotic area. That has been another question that has been asked from you in the past. That what is the black? This is the necrotic areas. Why? Because this is an angioinvasive fungus, invades the endothelium of blood vessels, causes thrombosis. This thrombosis leads to ischemia, which leads to necrosis. Yes. So you will now take a swab, a nasal swab, and you will also take a biopsy, and you will send it for microscopy, for histopathological examination, and for culture. On microscopy, what you will see? You will see ribbon-like aseptate hyphae branching at right angles, right? And histopathology, what you will see will be the necrotic areas. You will see angioinvasion. You will see the perineural invasion. Yes, all these things. In the culture, you will grow this fungus. Yes, so what is for diagnosis is microscopy. And for that, you will need to take a nasal swab. And also, yes, biopsy, but you will not wait for the culture or the biopsy report. Immediately when you get the microscopy finding, you will start the patient immediately on the management. So the next, yes, looks like the nasal swab. Let us see the other choices. Serum ferritin. Why for diagnosis? No. HbA1c. Yes, this is a diabetic patient. But now we want to diagnose what? Mucormycosis. So for that, the next step will be a nasal swab, not a HbA1c. Yes, HbA1c we will do, but that will not be the immediate next step. We have confirmed that this is mucormycosis. Now the management will be immediate start on IV amphotericin B. Along with that, do extensive surgical debridement, and along with that, control the underlying immunosuppression. For that, you will have to see the HbA1c and control the sugar levels and control that. Yes. So the answer here is B. Coming to the next question, a 20-year-old male presents with a history of unilateral nasal obstruction, recurrent bleeding from the nose for the past 1 year. On examination, endoscopy was done and the result is shown below. Okay, what are we seeing in the endoscopy? We can see a very red vascular mass, right? Okay, so what is the next given in the question? CT scan shows a contrast enhanced mass going from the posterior corner to the nasopharynx. Which of the following is most likely diagnosis in this patient? So the history, a young male with unilateral obstruction, nasal obstruction and recurrent epistaxis. This itself gives us the inclination that the diagnosis is angiofibroma. Yes. And does the endoscopy also point towards that? Yes, a red vascular mass. CT, yes, a contrast enhanced. So this is a very vascular mass, so it enhances on contrast. So yes, a contrast enhanced in the nasopharynx. So yes, all these features point towards the diagnosis as angiofibroma. Yes, so the answer is angiofibroma. Why not antroconal polyp? Can antroconal polyp occur at this age? Yes, it can occur in young males. It can occur, but yes, it can also lead to unilateral nasal obstruction, but recurrent bleeding in polyps never bleed. They have very little vascular supply. Polyps never bleed. Second, this appearance on endoscopy, polyp appear pale, grape-like, and CT scan will not be enhanced. So nothing is going in favor of polyp. Rhinoscleroma at this age can occur, can lead to, it is rhinoscleroma, it usually leads to bilateral involvement and bleeding. This CT appearance, no. What is the appearance of the nose in rhinoscleroma? It is a hard woody nose. In the side the nose you see lots of crust. Yes, you will see granulomas. No, not this. So it cannot be rhinoscleroma. Concha bullosa presentation will not be epistaxis. It can be obstruction only, and CT will show what? Pneumatized turbinate. So again, it is not concha bullosa. So here it is A. The next question. An adult male in a restaurant suddenly begins choking on his food. He is conscious. The following step was done, identify the procedure. So what we are seeing is, yes, undoubtedly, unmistakably, this is what is the Heimlich maneuver. Yes, so Heimlich maneuver is also known as abdominal thrust. And when you do it when the patient is conscious but is in respiratory distress, when he is having the universal choking sign. He is holding his neck like this. He is not able to breathe. He is not able to speak. He is not able to cough. Yes, if the patient is unconscious, you never go for Heimlich maneuver. If it is a child less than 1 year, you never go for Heimlich maneuver. In that case, what you do is, in that case, you go for back slap, you go for chest thrust. Yes, and also back slap or back blows can be given whenever you have found somebody who is choking on food and the patient is conscious as well as there is no respiratory distress. In that case, you can encourage coughing or you can give back blows. That you must have seen. That is a normal response when we find anybody choking on food. Yes, and I told you that Heimlich maneuver is abdominal thrust, that is not chest thrust. So when do we give chest thrust? We give chest thrust when it is an infant. When the child is less than 1 year, we cannot give Heimlich maneuver. Another place where we can give chest thrust is whenever the patient is very obese. Yes, or in pregnant, where you cannot, in the patient when he is obese, when you cannot put your arms around and reach his the area just below the sternum to do a Heimlich maneuver. When you cannot do that, you give him chest thrust. Also in pregnant females, you would never give Heimlich maneuver, you go for chest thrust. Yes, blind insertion of finger is never done in any case. If you are seeing an infant and you can see the foreign body inside the mouth, you can do an insertion of the finger, that is known as a sweeping maneuver, with the help of the finger to take out the foreign body, but that has to be done only when you are seeing the foreign body. It cannot be, the foreign body is visible, only then you can do it. It cannot be done blindly. You might push the foreign body further deep and it can lead to further complete asphyxiation, right? So yes, clearly the answer here is Heimlich maneuver. Yes, not back slap, not chest thrust, not blind insertion. So quickly, let us see what the steps should be whenever a patient starts choking on food. The first step is to encourage coughing, back blows, back slaps you can give. And if the patient is having the universal choking sign, always please note the patient should be conscious, and this is what is universal choking sign. Then you go for the Heimlich maneuver, also known as abdominal thrust. And if the nobody is available to give abdominal thrust, patient can himself do it by pushing the chair at just below the sternum. That is what is known as chair thrust. And if the foreign body is visible, only then you go for finger sweep maneuver. And if in spite of all these, the first aid fails, the patient cannot be intubated or cannot be oxygenated. That is known as the CICO, C-I-C-O. When can't intubate, can't oxygenate. Of course, we cannot intubate this patient. There is a foreign body which has got stuck. How will you will not intubate and push the foreign body further down. Yes. So if you cannot intubate and cannot oxygenate, in that case, what is the next maneuver is to go for the emergency cricothyrotomy. What is cricothyrotomy? Cricothyrotomy is you give an incision in the cricothyroid membrane in between the cricoid and the thyroid, and you put a tube here which just buys you some time so that you can shift the patient for removing the foreign body by a laryngotracheobronchoscopy, or you can shift to an alternate method of respiration. So it is just for buying time. So ultimately you have to take up the patient for a laryngotracheobronchoscopy. Yes, that is a rigid bronchoscopy or rigid laryngotracheobronchoscopy to remove the foreign body. Okay, now coming to the next question. Now these two questions, I have put two questions here which were very much integrated type of questions, not specifically related to ENT, and specifically they will be done in other subjects also by other faculties, but I have put it here just for you to see how the integration of the questions is likely to be in the future also. So here it is, which of the following conditions is not caused by high risk strain of human papilloma virus? Yes, so earlier when the questions used to be asked was asked which of the following is not a high risk strain. That was a question of microbiology, right? Or which is the high risk strains of human papilloma virus. But see, now they have not asked like that. What they have asked is that which of the following is not. What is asked is not caused by high risk strain. So you are supposed to know, yes, two things. First, which are the high risk and which are not the high risk. And second, these conditions are caused by which. Yes, so we know that cervical cancer, anal cancer, roller cancer, very commonly they are caused by HPV 16 and 18. 16 and 18, 16 and 18, and repeatedly has been a question, laryngeal papillomatosis has been caused by. That's a repeated question in the past by 6 and 11. So which one here is by the not by high risk? Yes, we know this is not by high risk. Now I have marked 16 and 18 cervical cancer. There are many high risk strains, but these are the very important high risk 16 and 18, and definitely the non-high risk is 6 and 11. We have to remember that laryngeal papillomatosis is caused by 6 and 11 when it has been asked in the past. One more question has been asked there is that out of 6 and 11, which is the more virulent? So out of 6 and 11, more virulent is the 11. Right. Now another similar question we have, which has been an integrated question. A 40-year-old male presented with ulcer on the dorsum of the nose. So there is ulcer on the dorsum of the nose which is increasing in size. Biopsy was done and histopathology shows the basophilic cell bundles with palisading nuclei. Most likely diagnosis is. So only the histopathology, I've just mentioned the histopathology as what was given in the histopathology. The histopathology specimen was also given, I think. Now, as clinician, right, when a patient like this will come, or when I see a question like this, that there is a patient who has an ulcer on the dorsum of the nose, which is increasing in size. Yes. And when I see that, I have to choose between the choices, all of which have a carcinoma. Yes. So what is the carcinoma that will come to my mind? To my mind, what carcinoma should come? Yes, what is the most common carcinoma of the external nose? It is a basal cell carcinoma. So I will take a biopsy and I will send for histopathology. The histopathologist will see the pathologist will see what is being seen there, and that is the basophilic cell bundles with palisading nuclei, and and he will send me the histopathology report that it is a basal cell carcinoma, right? I will not know how to diagnose a basal cell carcinoma on histopathology. But by seeing this question, I can make out that the answer will be basal cell carcinoma. Is that clear? Yes, what I intend to tell you here is that whenever it is an integrated pattern question, don't be sad that nowadays integration is being asked. That is for your benefit, because whenever integration is being done in a question, you will have multiple key points. You will have key points from the point of view of the clinician also, and from the point of view of the paraclinical areas also. So even if you are clear with one area, you will be able to diagnose that this is the answer. Yes, so this in detail will be dealt in in pathology. But yes, I wanted to include this question here. As a clinician also, I can make the diagnosis, this is basal cell carcinoma, so can you. So those were the questions of NEET. And again, before we end, yes, 1 minute I will like to take of yours. Yes, do you know the power of revision? Yes, we have heard it so many number of times from all the toppers that revise at least 3 times, at least 3 revisions you have to do, so that that thing becomes one with you and you are able to answer the questions correctly. Yes. So when revision is so powerful, can you imagine the amount of harm that you are doing to yourself when you are repeatedly revising the negative thoughts of disbelief in yourself, negative thoughts of your incapabilities, not only every day but multiple times throughout the day? Yes, realize the power of thoughts. Always know that your thoughts lead to your actions, and ultimately you become what your thoughts are. So yes, do not let any thoughts negative, which are not aligned to your goal, come to your mind, especially at this time when your exams are very near. Yes, so what you can do is you can do the reverse. You know that whatever your action is first a thought. So what you can do is you can replace all those negative thoughts of disbelief, of incapabilities. You can just turn it, you can remove it and replace it with all the positive thoughts which are aligned to your goal. Yes, and whether you believe me or not, it costs you nothing. You know that it costs you nothing, and it works wonders. Yes, so there is no reason for you not to try it. Believe in the power of thought. Yes, the moment you start replacing all those negative thoughts with positive ones, it will be difficult. It is not going to come in one day, but once you practice, you will see that you are becoming what your thoughts are. Yes, and if they are positive, you have no idea to what you can become. So all the best. Love you all.